Hello and welcome to this presentation on molecular and multimodal imaging and theranostics of prostate cancer, current state of the art. My name is Wolfgang Weber and I'm trying in this brief presentation to give you an overview what has happened in this field during the last 3 or 4 years. First, my disclosures. I've worked with several companies that are involved in the field of theranostics and have received research support and have acted as a consultant for these companies. As an FDA disclosure, I want to mention that I will discuss non-FDA approved radioligands that are in clinical development. Now, only 5 years ago or so, it would have been a struggle to fill 12 minutes with information about molecular imaging and prostate cancer. This has now really changed, and now the struggle is to make sure to shorten the presentation in a way that you get somewhat of a comprehensive overview of what has happened in prostate cancer in the last 5 years. And this is indicated by this relatively busy slide, which shows you on the top FDA-approved imaging agents and their targets, and at the bottom investigational agents that are in clinical trials for imaging and treatment of prostate cancer. With this, I want now to continue with the main topic of my presentation, which is PSMA, or prostate-specific membrane antigen. PSMA is a glutamate carboxypeptidase. It's an enzyme, and it is very highly expressed in primary and metastatic prostate cancers. It can be targeted with antibodies, but the clinical breakthrough have been these enzyme inhibitors that bind to the active site of PSMA, but the PSMA enzyme cannot cleave them, and they basically get stuck in the active center of the PSMA molecule and therefore are taken up by prostate cancer. An advantage of these compounds, and this is also a big part of their clinical successes, that these inhibitors can be labeled both with a positron-emitting isotope such as gallium-68 for PET imaging, or a therapeutic isotope such as lutetium-177 for targeted radionuclide therapy of prostate cancer. All the work that I've shown you so far has performed with one ligand called gallium-68 PSMA-11. There is quite extensive clinical experience, even this randomized controlled trial. Nevertheless, this ligand has a limitation, and that is that it can only be produced in relatively small batch sizes because the radioisotope, the gallium-68, is only available in relatively small amounts per synthesis. And therefore, it is difficult to produce this in large amounts and ship it to sites that don't have a radiochemistry to perform the labeling with the gallium-68. But the next ligand in this table, which is called F18 PSMA-1007, also a F18 labeled compound, again, can be produced in large batches, but what is different from F18 DCF-PYL is that it has a low renal excretion. The concentration of activity in the urinary bladder is substantially lower than for these other agents, and therefore evaluation of local recurrences is easier with this compound as compared with the gallium-labeled compounds above and the F18-labeled compound. An unexpected observation, however, with this compound has been that there's a higher frequency of non-specific uptake in bone and lymph nodes, and I will show you some examples for this in the next slide. So this slide shows you the higher frequency of non-specific uptake in lesions that are not related to prostate cancer with the PSMA-1007 compound. And you see on the left side of the slide in this bar graph, the frequency of lesions that by evaluation of the CT and the clinical history of the patient were very unlikely to represent metastatic prostate cancer. And you see that these number of lesions shown in orange, we saw in this matched pair comparison of 2 times 102 patients, we saw these benign lesions in 52 patients with the gallium PSMA-11, but in 245 cases with PSMA-1007. So this is not a small, but a quite substantial difference. And on the right side of the slide, you see examples for this. One is a bone lesion, is a subtle rib fracture that is seen on the CT. Typical features, very intense uptake, however, on the PSMA-1007 PET scan. And the other is an inguinal lymph node, which is not much enlarged. It's in a location that is very unlikely to be involved in metastatic prostate cancer, but still demonstrates quite intense uptake of the PSMA-1007 ligand. These cases occur significantly less frequently with the PSMA-11 11. At the bottom of this slide, you see basically the distribution for the two agents. What are the typical reasons for non-specific uptake? And the non-specific uptake with the PSMA 1007 is a mixture of basically uptake in lymph nodes, bone lesions, but also in those ganglia which express PSMA but are unrelated to prostate cancer, obviously. In this slide, I want to introduce to you the radiohybrid or RH ligands, which can be labeled with both gallium or lutetium and fluorine-18. So basically, those ligands include a chelator that can be used to label the compound with a metal, such as gallium, and they can also be labeled at a different site with the fluorine-18. So the advantage is that with these compounds, you can use the identical compound for imaging and potentially therapy, or if you like, you can label the compound with gallium and have then a stable fluorine at the time of imaging. And the initial evaluation of these compounds was also quite promising, as shown in an example on the right side of the slide, where you see a patient with a local recurrence of prostate cancer and two small lymph node metastases that are very well visualized with this RH PSMA ligand. This ligand also has just started evaluation as in phase 3 clinical trials, and one will have to see how it performs in these clinical studies. In some patients, these ligands are exceptionally effective. This is an example from our own experience, a patient that presented in 2014 with very extensive bone metastases. So the scan on the left side of the slide is not a bone scan, it is a PSMA PET scan with very extensive disease involving diffusely the multiple bones. And after 4 cycles of treatment with this PSMA INT ligand, you see that the PSMA PET scan is basically normalized and the tumor marker PSA has basically dropped into the normal range. The patient then developed a recurrence in 2016, which was again successfully treated with 4 additional cycles of PSMA INT. As another recurrence occurred in 2017. Again, this was successfully treated. And in 2018, again, the patient was treated. You see that more residual disease remains after these individual treatments, but still it is quite impressive that a patient with such extensive metastatic disease and after having received all approved therapies for metastatic prostate cancer is still alive and doing quite well 5 years later. What's also remarkable is that these PSMA theranostic agents have developed so quickly. The first human study was published in 2015. The first phase 2 clinical trial was published in 2018. And the phase 3 clinical trial has started also in 2018. And until phase 3, development was solely performed by academic centers without industry support. That's a very encouraging example how academia can actually produce drugs that can be quite effective. Now, I don't want to give the impression that in every patient, the treatment with lutetium-labeled PSMA ligands is as effective as in this one patient I showed you. This is our more realistic experience in 100 consecutive patients whom we treated with lutetium PSMA INT. And you see on the left side the waterfall plot, which summarizes the changes in PSA after treatment. And you see this can be roughly perhaps separated in 3 groups. There's about 1/3 of the patient that the treatment is not effective, the PSA actually increases after treatment. Then there is one group, maybe also about 1/3 of the patient, that has some decrease of the PSA, or at least not a further increase of the PSA, so where the PSA changes between 10% and maybe 50%, and then there's another third of the patient where there's a quite substantial change, up to a 100% change of PSA, such as in the one patient that I showed to you previously. On the right side of the slide, we see the survival of the patients separated between patients that had a PSA response and patients that did not have a PSA response. As expected, this was statistically significant difference between those 2 groups. But I think what is overall quite encouraging that the median overall survival in this patient population was about 13 months, because all of these patients were only included after they had failed all approved therapies for metastatic castration-resistant prostate cancer. So these patients had no other therapeutic options, and still, in median, they survived for almost 13 months after the treatment with the lutetium PSMA INT. The experience with the PSMA 617 is quite similar. This is from a recently published study from the group of Michael Hoffman, and it shows you the PSA decline. similar waterfall plot that I've shown you in the previous slide. It may appear that the response rate is higher than what I've showed you for the PSMA INT. However, I would like to point out that the patient population was less advanced than the patient population that we treated, and especially the fractions of these metastases in liver and lung was substantially lower than in our patient population, which probably explains the more favorable responses that was seen in this study as compared to the study in PSMA INT I showed in the previous study. The median overall survival was actually quite comparable with 13.5 months as compared to the 12.9 months that I've shown you in the previous slide for the PSMA INT. Results presented so far in abstract form and at the ASCO meeting show a clear superiority of the PSMA 617 as compared to chemotherapy. The PSA response, which was the primary endpoint in the study, was 66% for the lutetium PSMA 617, but only 37% for the chemotherapeutic agent. So there's also at least the potential that this PSMA 617 treatment can be used at earlier stages of prostate cancer and not only at these very advanced stages that are included in the VISION clinical trial, the randomized phase 3 clinical trial. So to conclude, what I wanted to show you in this brief presentation was that molecular imaging has made very rapid progress in prostate cancer. Several PSA targeted imaging agents are in phase 3 clinical testing. And PSMA targeted radionuclide therapy has shown significant promise for metastatic castration-resistant prostate cancer in clinical series and phase 2 studies. And very importantly, a phase 3 results for this PSMA targeted radionuclide therapy are expected for 2021. Thank you very much for your attention.